I'm Grace Halsey, Senior Editor at Patient Care Online, website for primary care physicians. And our clinical focus this month is on preventive cardiology and the essential role of primary care in helping patients reduce their risk for cardiovascular disease. And today, Ted Kyle is with us to talk about obesity as a risk factor for cardiovascular disease and how obesity management can help mitigate the effects on cardiovascular health. Ted is a pharmacist and a health innovator who lives in Pittsburgh, Pennsylvania, and a tireless advocate for people living with obesity. Good morning, Ted.
Good morning, and thank you for having me join you, Grace.
So we've understood for some time now that obesity is far more than the result of poor dietary habits. And in fact, it is defined as a chronic and relapsing disease with a very complex etiology. Could you just provide some background for primary care on the evolution of that thought process?
Sure. It was in 2013 that the AMA came to agree with the NIH and various specialty societies who figured it out that obesity is a chronic disease back as early as 1998. But really coming to terms with that has taken time. The fact is, and it's appreciated by people who specialize in treating obesity, that obesity is a chronic disease. It's a complex chronic disease. It's probably a collection of different forms of this chronic disease, just like cancer is a very heterogeneous condition. There are things in common, but there are different etiologies at work. However, to simplify it, what we do know is that an individual's risk of obesity is about 70% determined by their genetic makeup. Now, that genetic makeup interacts with the environment so that susceptible individuals have obesity triggered by what we call an obesogenic environment, whereas people who are genetically resistant to obesity will not have that same trigger from an obesogenic environment. And there are many different elements of our environment that tend to trigger obesity. What we do know is that the environment has changed so that that environment is triggering more obesity today than it was 30 or 40 years ago, and that's why we have more obesity. Genes haven't changed. The fortitude of people for making good choices hasn't changed. The environment has changed, and it's triggering more obesity in susceptible individuals.
Do you think that there is an appreciation at the primary care level of the complexity of the disease in terms of treatment?
Well, if you want to talk about obesity, I find that I always get into trouble when I try to make generalizations. So there are very many folks in primary care who do not understand obesity as anything more than a behavioral condition. There's a lot of that, and it's a false construct for what we know to be a physiologic condition, but nonetheless it's prevalent. But there are plenty of people, and a growing number of people in primary care, who understand the complexity of obesity, who see the way that their patients struggle with this physiologic condition, and they come to realize that it's not adequate to simply advise the patient to lose weight, as has, for so many years been the approach to it.
So this is a slightly broad topic, but what do we know today about the effect of obesity on the structure of the heart and the burden of obesity on cardiovascular health?
Well, we do know that obesity causes an increased risk of diabetes, which brings an increased risk of cardiovascular disease. We know that high blood pressure and dyslipidemia are more prevalent when a person has obesity. We also know that treating obesity, and this is why that we know the association is causal, can reduce those risk factors. We know it from behavioral treatment in the diabetes prevention program. where there was significant reductions in high blood pressure, improvements in lipid profiles, and reduction in the progression of prediabetes to diabetes. We know it from the surgical treatment of obesity at the other end of the intensity of treatment, where treatment with gastric bypass surgery is known to put diabetes into remission and to reduce the mortality from cardiovascular disease. And then in between, with pharmacotherapy, we know that pharmacotherapy can reduce the progression of prediabetes to diabetes. We know that it improves cardiovascular profiles and lipid profiles and A1C.
Which leads into the next question, which is the profound effect of obesity on other cardiovascular risk factors, which you just discussed: diabetes, hypertension, also heart failure, arrhythmias, obstructive sleep apnea. Obesity is another layer of morbidity on top of these and fuels them, and the other way around.
You're exactly right. And Dr. Steve Nissen at the Cleveland Clinic has recently published some commentaries and data that point to obesity as a factor in a slowing or halting, or perhaps even reversal of the progress we've been making in reducing deaths from cardiovascular disease. For decades, we've been able to reduce the deaths from cardiovascular disease. But as the prevalence of obesity has risen to now 43% of the population in the US, that increased prevalence of obesity brings greater risk of heart disease, which has led to a slowing of the progress in reducing death from cardiovascular disease.